Welcome to Current Affairs. My name is Nathan Robinson. I am the editor-in-chief of Current Affairs magazine. Today we are discussing the state of abortion access in the United States. And I am here with one of the foremost experts on reproductive rights in America, Professor Carole Joffe. Professor Joffe, hello. Nice to be with you.
Nice to be with you, Nathan.
Carole Joffe is a professor in the Advancing New Standards in Reproductive Health program in the Department of Obstetrics, Gynecology and Reproductive Services at UC San Francisco. She is the author of a number of books, including The Regulation of Sexuality, Experiences of Family Planning Workers, Doctors of Conscience, The Struggle to Provide Abortion Before and After Roe v. Wade, Dispatches from the Abortion Wars, The Costs of Fanaticism to Doctors, Patients, and the Rest of Us, and most recently, Obstacle Course, The Everyday Struggle to Get an Abortion in America, co-authored with David S. Cohen. I have mentioned that she is one of the foremost reproductive rights experts in the United States. That's not just my opinion. Michelle Goldberg of the New York Times says nobody knows more about reproductive rights than Carole Joffe. She is a recipient of a Lifetime Achievement Awards from the Society for Family Planning and the Abortion Care Network, and she is also a graduate of my alma mater, Brandeis University, which, so a proud fellow Brandesian.
Oh, wonderful.
So the reason I wanted to talk to you is because I think in a lot of the abortion discourse, a lot of it focuses on law and policy changes. We talk about time limits, we talk about different restrictions that are allowed and permitted, but your work over the course of your career, what you have focused on in a number of your books and pieces of writing is how these legal and policy changes actually affect people on the ground. You zero in on the real world of women and doctors and abortion counselors and people in families to talk about what it actually means to have various restrictions or not have them. And this book, Obstacle Course, is about what it is actually like for women to try and get abortions. So maybe we could start, if I could ask you, what is left out of the dialogue around abortion that from your interviews, from your research, you really see on the ground?
Well, let me start here, Nathan. Now 1 out of 4 women are expected at some point in their life between the age of, let's say, 15 and 45 to have an abortion. 2 things flow from that. 3 out of 4 women don't. Mm-hmm. But I think more to the point, people don't talk about their abortions. There's a lot of stigma.
I know that God don't want this for me, but I did pray on it. I just want him to understand that I feel like I should go through with it. Mm-hmm. I just want him to understand, and I don't want him to be upset with me because if I do it, I'm not a good person at all. I just feel like a bad person, a bad female.
Mm-hmm. So the extraordinary difficulties that people, and I will use people and women in this interview interchangeably, sure, if that's okay.
Yeah.
So people don't realize how extraordinarily difficult it can be. People also don't realize the incredible toll that it takes on abortion providers in many cases to provide this service, given the harassment, given the legal harassment, given the physical harassment, and so forth.
Growing up in Alabama and knowing how aggressive people can be when they feel strongly about something, I said, there's no way I'm going south. But I found myself overwhelmed by the compassion I felt for my patients.
People have said some very obnoxious things, like calling me the Negro abortionist and saying I kill my race, that kind of thing.
They're trying to wipe out the black race, if you noticed. They're trying to wipe them out.
We like black babies. Black babies matter to us, but apparently not to you. And you don't care one bit because you're pro-choice. You stand beside those folks. Good job. Good job. You're a disgrace to your race.
As you point out, Nathan, in general, people don't really talk about the realities of what it means to have to get an abortion. I'll give you an example.
Yeah,
I mean,
please.
I've studied, as you've pointed out, I've studied this for many years, but it was not till my co-author and I did interviews for our last book that one of the people we talked to talked about a patient who had sold the family dog so she could help pay for the abortion. And,
Yeah.
It's that kind of detail that I think has been
Yes.
missing.
Right now, I'm kind of relying on government assistance until I find a job. So I just didn't have the money for the abortion. So that's why it took me so long. That is $460. I paid $600 total. I just had a birthday, so I took some of the birthday money I had. And it was also a fear. Like, my mom, she doesn't believe in abortion.
When I was 19 years old, I worked at a Planned Parenthood clinic for a summer, and one of my jobs was to book abortion appointments for women, and I had to get them to take the questionnaire if they couldn't pay for it, and I had to go through all these things that would, if they answer the questions correctly, they get a subsidy. And, it wasn't until I did that I understood that what the problem with means testing things, because you're forcing people to disclose parts of their life in order to get access to this medical procedure. And there was the memory that stays with me strongest is I talked to a woman whose house had just burned down. And, and she needed abortion because her house had burned down. So of course she obviously could not afford to have a child at that moment in her life, but she also didn't want to revisit traumatic, right? I mean, unearthing this stuff just so she could get this necessary medical procedure paid for. Even though the subsidy program was quite generous if you were under a certain income threshold, seeing that even the questionnaire was this obnoxious, difficult burden is something that I didn't notice until I actually went to work in the clinic. And that's true for a lot of stuff, right?
Yeah, well, I mean, in the non-abortion world, we are now, as a society, dealing with that very issue. The reconciliation bill now being discussed in Congress. Progressives want the programs to be universal. The Joe Manchins of the world want it only targeted toward the poor. What we know from years of looking at social policy, well beyond abortion, is that when programs are universal, not means tested, they're usually better. Mm-hmm. And with respect to abortion, 17 states actually allow Medicaid to pay for abortions. Now, Medicaid, of course, is means tested, mm-hmm. but at least if you're in a Medicaid state, you automatically get your abortion paid for. You don't have to go through the kind of interview that you, Nathan, had to do with the people you spoke to.
Yeah, I mean, one of the book is called Obstacle Course, and you discuss the many different kinds of obstacles, but one of the major ones is paying for it. And it, again, when you actually focus in on the stories of people who are trying to find the money somewhere to pay for their abortion procedures as the clock is ticking, I mean, you realize just what an addition. I mean, this is an unintended pregnancy is such an inherently stressful part of a person's life. And then added on top of that is the question of whether they're going to be able to come up with the money in time.
Mm-hmm. That's right. But what I found out when we did the interviews for this last book, and I started doing this work around abortion in the 70s, so I've been looking at it over time. And one thing that has occurred is people are the pool of people getting abortions has been getting poorer and poorer. That's in part because there's better contraception available now, but it's expensive. It costs $1,000 to have the latest version of so-called LARC, long-acting reversible contraception, which it's an IUD, an intrauterine device, which is very effective and very cost-effective because the last 10 years, but poor people don't have $1,000 up or $800 sometimes up front. But Nathan, it's not just paying for the abortion. It's paying for travel. A lot of travel going on now. It will be even more so should Roe versus Wade be overturned, which is quite likely. You pay for travel, you lose a certain amount of wages. Many states have waiting periods. So you have to you drive maybe 500 miles to the nearest clinic, and if, for example, in Texas, which of course now has almost no abortions, but even when they had them, you come one day, but you have to come again the next day. Some states have 72-hour waiting periods, Utah, for example. So you're talking 2 nights of hotel and lost wages and childcare. 60% of abortion patients already have children.
I'm going to be doing your ultrasound, okay? If we see any heartbeat whatsoever, we cannot proceed in the state of Texas, okay?
I can't support 2, let alone go to work, do all that I need to do. I drove from Waco to come down here because they don't have any clinics that I could have seen. Knowing that I have to go all the way over here just to do what I need to do is kind of like, it's hard. It's a lot.
There are a number of things that I think people who know that there are obstacles in the abstract, reading your book will find out a lot more about what that actually means in people's lives. And I mean, you talk about how difficult it is when people, they need to find something to do with their kids. The clinic is a long way away. You have stories of people sleeping in the parking lot of clinics, and also that when it affects mostly poor women and also mostly women of color, as you point out, and there are things that you don't have yourself, but maybe you have a family member or a friend who could help you with. That's another person that you have to talk to about your abortion. So, and this additional burden of stress and discomfort.
Yeah, no, I mean, let's back up. In general, poor people have more difficulties accessing healthcare than non-poor people.
Right.
We know that. The real kicker about abortion, though, is the stigma. If, for example, in rural areas, there's not always readily available healthcare. Yeah. Sometimes you need to drive a long distance. That's true. But you can ask your parent, your boyfriend, your friend, can you drive me tomorrow to such and such place? I need an ultrasound because of my kidney stone.
Right.
It's a very different kettle of fish when you have to assess who can I tell, who can I ask to drive me to get an abortion. And that's really, one key theme of our book is something we call abortion exceptionalism. It refers both to legal issues. So, for example, legally, abortion is treated very differently than other medical procedures of comparable complexity or lack of complexity in the case of abortion. But we have extended this concept to other issues as well. It's abortion exceptionalism, for example, that means it's very difficult to ask other people to help you unless they are very trusted.
I mean, there are things in this book. Again, I worked at making these abortion clinics when I was young, and there are things that still shocked even me. I mean, I had to drive through a crowd of protesters, right, to get to work. So I knew about certain things, but you open with this story about one of these crisis pregnancy centers, basically building like a fake abortion clinic next to the actual abortion clinic, hoping that they can get women to go into this fake clinic where they basically lie to people and they say, oh yes, we've been expecting you, and then they give them all this propaganda. I mean, the ruthlessness of abortion opponents in waging war essentially and finding every little, this is not an obstacle course because it has arisen naturally, but because is a very, very committed movement dedicated to throwing as many obstacles in people's way as possible.
Yeah, no, the crisis pregnancy centers are a real problem. Like you said, the pattern has been this: whenever possible, to buy the building or buy the lot next to a clinic, have very similar name. An abortion clinic will be called, let's say, Women's Health Services. So the crisis pregnancy will call itself Women's Health Clinic, and how are patients supposed to know? When patients drive up, people from the crisis pregnancy center wave them over. And what I didn't really know till we started doing this is there's thousands of these crisis pregnancy centers, far more than there are abortion clinics at this point. A number of red states, including Texas, gives thousands and thousands and thousands of public dollars to these crisis pregnancy centers, which are often run by religious groups. And they take the money. I mean, no state publicly funds, none of these red states publicly funds abortion, but they take the money away from family planning programs. So instead of going to a clinic and getting contraception, you now go to a crisis pregnancy center where you get pep talks about how not only abortion is bad, but also so is contraception.
What is the mission of Women's Choice Network?
We're here to empower abortion vulnerable people to choose life.
Did you feel misled?
Yes, absolutely. I mean, it's called Women's Choice Network. I would have thought it would have been, at the very least, a referral to let me know about other abortion clinics.
I think one of the important points about some of the obstacles that are thrown in women's way is that some of them don't actually really succeed in deterring or changing women's minds, but what they do succeed in doing is making sure that any woman who has an abortion is going to have a more stressful, unpleasant, or traumatizing experience. Like some of these, I mean, you talk about these states that require them to show the ultrasound, even if you don't want to see the ultrasound. The same is true with a lot of the protesters, right? I mean, certainly, I remember my experience was very few people were turned away by the protesters or didn't go because they had to wade through a crowd of protesters. But certainly when they came in, they were deeply agitated.
Come and talk to me just for a second. My name is Tanya. I'm a registered nurse. Used to do mama baby nursing. I can tell you how abortion is going to hurt you. You'll never be the same again.
One of the protesters told me, just don't go in that door. Just keep your baby. They'll be here by Christmas. You'll have a beautiful Christmas baby. And it just, you want to say something back. Your natural reaction is to defend yourself.
They do succeed in making sure that women who have abortions feel the stigma.
No, you're absolutely right about that. However, I do want to point out that the abortion providing community, the doctors, the counselors, the clinic managers, the clinic staff, the medical assistants, I mean, they try very, very hard to counteract this. I mean, some of the most humane, I'm a medical sociologist, so it's not only abortion that I know about, but the impersonality that we find very often in other medical settings, sort of paradoxically, because abortion has been under such attack. I mean, paradoxically, those who want to work in this field are obviously a very self-selected bunch of people. And I have seen extraordinary acts of compassion, of calming. In fact, several doctors at different interviews told me, one of the hardest parts because of COVID is, after the procedure, I would normally go hug the patient. So I think that gives you a window into the kinds of compensations that abortion clinic staff make in response to the screaming and the yelling that, bombards their clinic.
So for example, you got the idea that mothers and fathers should be able to bring their children into a death camp. They should be able to pay an assassin to dismember their child in the womb, tearing off the head, the legs, the arms, disemboweling that child. Their judgment is, that is good, that is righteous, that is good for society.
And one of the points that you raise in the book is that abortion providers want to make sure that the women who come in actually want to go through with the procedure.
That's true. Several doctors told us, that they had nightmares that, that they did an abortion on somebody who didn't really want one. I remember one clinic director telling me, we always say to patients, there's no do-over in this. Now, most people who show up in an abortion clinic have in social science jargon, have a very high decisional certainty. This has in fact been documented. Some of my colleagues at UCSF have actually done a study. They interviewed abortion patients versus breast cancer patients, and I forgot the other category, but after the procedure, do you feel you made the right decision? And, abortion patients came out very, very high. So most come to a clinic knowing exactly what they want. So yes, in a small number of cases, the clinic takes the proactive step of making sure people really are doing what they want to do. And again, a very small number.
Yeah. Yeah, I think one of the key points about waiting periods imposed by law is that it is explicitly overriding doctors' judgments about what their patients need, because any doctor who felt that a waiting period was necessary could say to a patient, well, I won't treat you for 24 to 48 hours. That would be a doctor's judgment in a world in which there was no legal requirement. But the law says we don't trust doctors to make judgments about what is good for their patients. So we're going to impose what we think of as sound medical judgment. Again, obviously, most legislators aren't doctors. And in some cases, one of the incredible things that you point out in the book is that in some cases, there's actually mandates for providers to tell lies to patients, to say things that they as doctors believe are untrue or misleading and that will scare people and give them a false impression of medical science.
No, I mean, this is shocking. I mean, just, you can't make this stuff up. In the United States, in a number of states, there's a state mandated scripts. You have to tell the patient that she's at higher risk for breast cancer. Not true. She's at higher risk for suicide. Not true. She won't be able to have children when she wants to. Not true. So this is a horrible bind. For health professionals. I mean, if health ethics means anything, it means you don't lie to your patients. I mean, that's a no-brainer.
Right.
Currently, I'm practicing in New York, but for a brief period, I was working in Texas. And if a patient came to get an abortion, I would have to do an ultrasound, whether or not it was medically indicated. I had to describe the ultrasound to the patient, whether they wanted to hear it or not. I had to read a state-mandated script, which included some misinformation, such as abortion causes breast cancer. Now, none of these rules, none of these laws are founded in science and do nothing to safeguard reproductive health. They only harm patients. Misinformation really just feeds and drives the stigma that I face, that my patients face, that this work faces.
And in many, patients who come to clinic are not necessarily well-versed in abortion politics. They don't understand the larger abortion war in the society. So some of the providers we talked to said to us, patients say to them, well, why are you telling me this?
Yeah.
Why are you making me freak out about breast cancer that my mother died of? By now it's been going on so long, it's become normalized, more or less. But it's really one of the shocking things that, and again, Nathan, I would raise the issue of abortion exception.
Right. What other domain do doctors?
Where else in medicine, when you go to have your broken arm in a cast,
I'm sorry, I have to read you this thing that says, your broken arm may cause all of these things. It doesn't actually cause, Well, and legally, I actually read an article about the Supreme Court's inconsistency on the question of compelled speech, because the Supreme Court often takes a very negative view of what's called compelled speech, right? On the First Amendment, the government making you say things is obviously inherently extremely coercive. So they say, well, the government making you pay union dues, that's coerced speech. But this is a case in which you have the most coerced speech imaginable, which is that you are telling a doctor that they have to say a thing that they believe to be untrue. I mean, it's explicit authoritarianism, really. I mean, it's a government telling you what you have to say, and as you say, it's kind of normalized. We don't realize how weird and horrifying and invasive that is.
Well, Nathan, it gets even worse, and we talk about this in the book. I mean, doctors are compelled to say things that are not true. Crisis pregnancy centers say things that are not true all the time, that abortion, you will die from an abortion, you will never have children again, you'll go to hell, et cetera, et cetera, et cetera. And the state of California actually tried to make crisis pregnancy centers at least acknowledge that they were not, that all their statements weren't true. And the state of California lost in court. I mean, it was a Supreme Court case.
Right.
And the Supreme Court said, well, it doesn't really matter what they say because they're not really, we can compel speech in a healthcare situation, but, since they're not really healthcare, they can say whatever the hell they want.
No, it's extraordinary. I mean, as I say, there has been a really, really ruthless effort and quite as we see in the recent Texas abortion law, really quite a clever and insidious way of building this giant labyrinth of obstacles. Over, as you mentioned, you've been studying this for decades. You've seen the changes that have occurred. Is it the case? I mean, my impression is that it is harder today than it has been in a long time to get an abortion, and that even before what we anticipate as the overturning of Roe versus Wade, that there has been a real significant increase in these obstacles thanks to the conservative movement. Is that the case? Are they really kind of succeeding in a way they haven't for a while?
Yes, and I think we can really pinpoint that. We can really go back to the 2010 election.
For Tea Party members, the prime example of big government and legislative excess is the Obama health care plan, or as Tea Party followers call it, Obamacare.
I have a message from the people of Kentucky. Tonight, there's a Tea Party tidal wave, and we're sending a message to them.
And I should say that the states are where the action is with respect to regulating abortion. I mean, bracketing what the Supreme Court, of course, will do next year. But so after 2010, we had a huge influx of restrictions, and which have continued to this day. I mean, 2021 is not over, and we've already had more restrictions than have ever been, put on before. I mean, there's somewhere between probably around 16, 17, 1800. I mean, we don't have the latest figures tabulated yet, but somewhere between 1,500 and 2,000 state level restrictions have been passed and implemented. So abortion is regulated to an unbelievable level, which has led, big surprise, which has led to a number of clinics closing, which of course makes abortion even harder.
Hope opened in 1980, and we provide abortion services. Our clientele comes from about a 3-state area. Our geographical area is about 200 miles. We have lost several clinics over the last few years through regulations. It was 7 in 2010, and now we're down to 3. I think for some clinic owners, the fight became too difficult to continue.
I'd like to welcome you all to Washington, D.C. for the 44th Annual March for Life. Life is winning through the compassion of caregivers and volunteers at crisis pregnancy centers and faith-based organizations who minister to women in the cities and towns across this country. Compassion is overcoming convenience, and hope is defeating despair.
Yeah, I mean, you point out that 90% of counties in the United States don't have an abortion provider. And so, the large distances people have to travel. And I think one point that I do just want to return to is the class divide here, or the way that every restriction necessarily falls hardest on poor women, and especially poor women of color, right? You cite in the book the excellent work of Michelle Oberman, whose Her Body, Our Laws book. It looks at El Salvador and looks at what happens in places where abortions are really heavily restricted. And one of the things that happens is that a lot of rich women are able to travel to places where abortion is legal. If you have the means, abortion often remains accessible. But the criminalization, the actual throwing people in jail, and all of the various hardships for abortion always fall the hardest on people who have jobs, people who have kids, and as you mentioned, most, or at least I think you mentioned in the book, but most people, 60% of people who have abortions already have children. And so, all of this falls the hardest on the people for whom the hardships are the most difficult.
No, that's absolutely right. And I mean, just to state the facts for your listeners, 50% of abortion patients in the US live below the federal poverty line, which is very low to begin with, another 25% just above it. So the face of the abortion patient today is a very poor woman who are disproportionately likely to be a woman of color. And I'm glad you mentioned my friend and colleague, Michelle Oberman's work, because it's very chilling. She has studied El Salvador, where women are thrown in jail, where women who are suspected of having an abortion is entirely illegal in El Salvador. Women who are suspected of trying to self-abort or having an illegal abortion are jailed, but women who have regular miscarriages are often thrown in, are also thrown in jail, because you can't really tell the difference. If a woman is pregnant and starts bleeding, either she's having a miscarriage or this miscarriage was induced. I invited Michelle to give a talk at UCSF a year or so ago. And as she was talking, we were all thinking, is this what's going to happen here?
Right.
And let me say, there's been a lot of talk now in the media of what will happen if Roe goes. And a big talking point of many well-meaning people, pro-choice people, is we will go back to the bad old days. Women died then, and they'll die again if, and you know what? That's well-meaning, but that's actually probably not true. Here's the situation. Before Roe, there wasn't actually that much legal surveillance. And it's not a big surprise. We didn't have the same highly organized anti-abortion movement we have today. Now, fast forward to the present. Let's say abortion becomes illegal in the United States, or at least in half the states, which will probably happen if they overturn Roe. A lot of women will no doubt attempt something we call, and we talk a little in the book, self-managed abortion. And the quote, good news relative to what happened before is getting medication abortion drugs off the internet, in fact, is very safe. And it's already going on. There's people already in this. Women in Texas, no doubt, are, in fact, I even think I heard some data the other week. Women in Texas are contacting a group called Aid Access, which is based in the Netherlands. They take a medical history, they send you, if you're an appropriate candidate, you're sent the pills. So the quote, good news is we won't have the thousands of women dying or being injured like we had before Roe. We won't have the same coat hangers that we truly did before Roe.
Right.
But the kicker is, we will have much more legal surveillance.
Yeah.
Already some women have been arrested for attempting their own abortion and have been imprisoned. I mean, nowhere near what Professor Oberman is describing in El Salvador, but similar. So the fears I have for the post-Roe era, if it comes to that, and I fear it will, is that we'll have a lot of arrests.
Yeah.
We'll have arrests of people who are attempting their own abortion. And I fear also we may have some arrests of medical personnel who attempt to help them.
The one sort of final thing that I did want to ask you, other than obviously participating in the political fight to protect abortion rights, is I think critical. But other than that, are there things that people can do that are useful? For example, contributing to abortion funds or providing transportation. I mean, what do you think the average concerned person who believes in abortion rights, donate to Planned Parenthood? What do you think are the most vital things that we need from ordinary people in the abortion fight right now?
Well, I'm glad you asked that. And the most important things are exactly what you just said, Nathan. One thing that became very clear to me as my co-author and I were researching this book, and I really didn't understand it till we did this research, is how extraordinarily important volunteers and advocates are. And again, it's abortion exceptionalism. Most branches of healthcare are not dependent on a network of kind-hearted Samaritans who are willing to drive people, who are willing to put them up, who are willing, to watch their kids while they have their procedure. I mean, it is really extraordinary the extent to which abortion in this country is dependent on this network of volunteers who escort at clinics. I mean, I don't know if you had escorts where you worked for Planned Parenthood, but many clinics have escorts who literally shield the patient, often, by holding a tarp over her head so she doesn't have to see the people screeching at her, calling her a murderer and holding signs saying she's going to go to hell. And let me say that, I was deeply, deeply moved when I heard these stories we tell a story in the book of a woman in her late 60s who went on literally on a 3-day odyssey with this woman she had never met before, because the community where the woman was supposed to get an abortion couldn't do the procedure because the woman was too far along, and she had very complicated health history. So this woman drove her from the south to Washington, D.C., and then at Washington, D.C., the clinic couldn't deal with her. So they drove to New York. She finally got her abortion. Then they drove home through a blinding thunderstorm. I mean, this level of decency just blew my mind.
My name's Joan McDonald, and I am here to greet patients that are coming into Planned Parenthood to help them get through the protesters. I want the patients to feel comfortable. The protesters are very threatening and sometimes aggressive, and so we like to escort them down the street through the protesters into the front door. And I think that for some patients, they feel safer.
Can you tell me why you're here today?
Almost 16 years ago, I was a patient of Planned Parenthood. I was accosted with pictures of abortions, and I had a fake doll covered in synthetic blood thrown at my face. And I had to walk the gauntlet that I defend every day.
My name is Betty. Everybody around here calls me Miss Betty. And what I do is I am available to you to talk to you about whatever's going on with you. What we usually do is do a group counseling where I tell you what to expect on surgery day. For me, being a mother is everything. Not only am I a mother to my 2 boys, I'm a mother to the rest of the women in this clinic.
But But I still have to ask the question, is this a way to do healthcare?
Sure.
What if this particular patient with this particular problem, who lived in a state with only one clinic that only went up to a certain number of weeks, and the city where the abortion clinic is also has a state-of-the-art university hospital. Why didn't she get her abortion in that hospital? Yes. And what happens to patients where there's not such a kind-hearted Samaritan?
Right.
So I am both very moved by this volunteerism, at the same time frustrated that that's what.
Yes.
That's how healthcare has to be done in this area of healthcare.
I mean, it's like when you see, these supposedly inspiring like GoFundMe campaigns for people's healthcare. You think, oh, it's so lovely, it's so inspiring to see all these people come together, and you think, but also, it shouldn't have to be that way. I mean,
exactly.
Chapter 9 of your book is called An Alternate Vision, and it's fun. It's always funny that you call it an alternate vision, because it's like a in this utopia, and the subtitle is Abortion as Normal Healthcare. Right? I mean, it's like this grand vision of what if this medical procedure was just treated as a medical procedure, and it's sad, really. I mean, we laugh, but it's sad that we are so far from abortion just being treated as healthcare. And of course, even then, because United States healthcare is so inaccessible and so unfair, even if abortion were on the level of other healthcare in this country, it can still be costly and it can still be inaccessible to people.
We are at a critical moment for access to abortion in our country. And I will not hide from the fact that as a provider of comprehensive reproductive health care that will always include abortion care, this moment is truly frightening. To some of you, this may still feel abstract. After all, it's happening far away, all the way in Texas. But we're here today because it isn't as far away as you may think. So now is the time to be loud and clear that abortion is health care and that cannot be delayed. Abortion care is safe. Abortion care is essential. Abortion care is normal. Abortion care is necessary. Abortion care is an act of love.
Well, Professor Carole Joffe, the book is called Obstacle Course, The Everyday Struggle to Get an Abortion in America, co-authored with David S. Cohen and out from the University of California Press. Thank you so much for talking to me. This was really illuminating.
Well, thank you very much.
The Current Affairs Podcast is a product of Current Affairs Magazine. If you are not subscribed to Current Affairs Magazine, visit currentaffairs.org/subscribe today and get our glorious print edition. The Current Affairs Podcast is released regularly every week on patreon.com/currentaffairs. Thanks for listening.